No.
Okay, this is our lecture today on the proper periodontal probe techniques. How many Americans have periodontal disease? A, 10 million, B, 54.6 million, C, 26.1 million, or D, 64.7 million?
C.
C.
D.
D? The answer is D. There are 64 million people who have periodontal disease. There are 318.4 million people in America as of 2014. That means there's 20% of America's population only diagnosed with periodontal disease. That doesn't include the patients that are actually undiagnosed with periodontal disease. I'm stressing periodontal disease in the beginning of our probe lecture because we cannot diagnose periodontal disease without the probe. In my opinion, the probe is one of the most vital instruments to a dental hygienist's career, and without this, we would be providing a less than quality care to our patients. So we can see here, I had told you guys that 20% of our nation's population has periodontal disease. Like I said, that's over the age of 30. You can also get periodontal disease under the age of 30. There's something called juvenile periodontal disease that happens very often in kids who don't take care of their gums as well. Some of our objectives of this lecture will take a couple of class periods. By the end of this lesson, you'll be able to identify the characteristics of a calibrated probe, identify the markings on probes that are in your student kit and that are also not in your kit. I also would like you guys to describe the rationale and technique for probing, explain where to sit while probing for a right and left-handed student, correlate probing to periodontal disease, explain the importance to a patient of probing, measure the clinical attachment level, and accurately record probing depths within 1 millimeter of the instructor's recordings in clinic. The definition of a periodontal probe. A periodontal probe is a calibrated tool used to measure the depth of a pocket. All of these periodontal probes have to be calibrated because they're universal. When I say they're universal, that means that they're used by dental hygienists throughout the entire world, not just the United States. They need to have the same markings so that hygienists nationwide can all get the same results. It's common that we get patients from overseas, such as India, Italy, England, places like that are very common to come to the United States and receive dental work. I'm going to start by going over a couple of the most commonly used periodontal probes and some that are in your student kit. The first type of probe that I'm going to go over is the University of North Carolina probe. It's a common probe in private practices. It's 15 millimeters long with markings at each millimeter. The thicker band is at 5, 10, and 15 millimeter markings. I don't know if you guys can see that where you're sitting.
I can see it.
There's thicker bands. This picture here also shows, each marking at each band. It goes all the way up to 15 millimeters. As we know, generally a healthy periodontal pocket is 1 to 3 millimeters. Anything over 3 is into the infection stages. I usually tell my patients 4 and 5 millimeters is generally inflammation, which means we're into the gingivitis stages. When we get above 5, there's definitely active disease going on and there's serious bone loss. This is a good breakdown, like I said, of what each marking means. This is another really common probe. This one's a little more difficult to see where you guys are sitting. This is the Michigan probe. This one has less markings. It has markings at 3, 6, and 8 millimeters. This is good for patients who are on the verge of gingivitis and periodontal disease. This probe takes a lot of practice to use since there are less markings. It doesn't give you a definite answer. You do a lot of guessing at the marking numbers. This, like I said, it takes a lot of practice, not just because of your technique, but because there are less markings. You have to focus and be more conscious about what number you decide, considering we do want to be as close to accurate as possible. When you're working in private practice, you want all of your hygienists to be within 1 millimeter of each other. This is another really common probe. However, in private practice, you will probably never see it. It's a very good tool to use, but it's just not common enough to be used in private practice. This is the neighbor's probe. It's used to measure furcation involvement. We know that furcation is the spot between the two roots of the teeth. You can sometimes detect the furcation when using an explorer or regular periodontal probe. You can sometimes see the bone level is low enough to be able to be recorded in x-rays. Whichever way you detect furcation involvement, you're then giving an opportunity to use this probe. You can see that the other probes were at a 90-degree angle. This one's curved. This one you can move underneath the gums and actually get between the teeth. Those three probes are the ones you'll see most likely in private practice. However, I said the neighbor's probe you won't really see in private practice. I'm sure if you ask the dentist if he had one, they probably do have one, because it's difficult to get a clear measurement. When you're measuring the furcation involvement, one is that you can just detect. That's the first marking. When you get to the black, the second marking, that means that you can actually enter the furcation involvement. 3 means you can pass all the way through, and the fourth and last marking on it means you can see the furcation involvement and you can pass completely through. Some factors that are affecting proper probing. There are factors that will affect proper probing. It will matter the type of probe you use, the amount of force that you use, the pocket depth, the presence of disease, presence of supra or subgingival calculus, and the position of the probe. All of these things seem very simple to control, but as a combination, they can make probing properly difficult. The type of the probe that you want to use can affect your measurements, because you would not use a UNC, the University of North Carolina probe, to measure furcation once it's been detected. Usually when you're deciding which probe you want to use, other than the neighbor's probe, it's strictly personal preference. The only one that matters, like I said, is the neighbor's probe when measuring furcations. When you are applying force and using your University of North Carolina probe, it is important that you do not puncture the junctional epithelium. We know that the junctional epithelium is the base of the pocket. It's a very thin layer of skin and it's very easily to be punctured. As easy as getting a paper cut, pricking your finger on a pin, things like that. So when you're applying force, you don't want to make this painful for your patients. It should never be uncomfortable when you're performing the task on a healthy patient. However, if it is uncomfortable, you may want to readjust your grip on the instrument, because that may mean your tactile sensitivity isn't as strong. The less of a grip you have on the instrument, the more sensitive your fingertips become. You may be gripping too hard, causing you not to be able to feel things like the junctional epithelium if you're applying too much pressure. Pocket depths can vary throughout the entire mouth. A patient with a healthy periodontium can have a 5 to 6 millimeter pocket. Now that pocket, like I had said earlier, when we get into 5 and above, can show us that there's periodontal disease active. However, sometimes things like an overhang from an old restoration, food impaction, things like that can cause a periodontal pocket. That's another thing that we'll study, but it's important to properly probe the entire mouth regardless the look and appearance of the gums, because we could have a perfectly healthy periodontium with some areas of slight bone loss. Presence of disease. When there's disease present, you will see inflammations of the gums. We know that signs of inflammation are things like redness, swelling, pus, things like that, even bleeding. Yeah, I saw your face. Pus isn't a good sign. Pus means that there is some severe disease going on, or possibly an abscess where a tooth may need a root canal. When there's inflammation, the measure of the pocket will be higher. This is the exact reason for the probe. Whether you are seeing slight inflammation from gingivitis or severe inflammation and bone loss from periodontal disease, it doesn't matter. That's what our probe is for. We will detect either way. When there's disease present, you could be experiencing bleeding and or pus like I had said prior. When there's a lot of bleeding present, it could be difficult to see the readings on the probe. Make sure you allow the patient to rinse often if there's a lot of blood. I know a lot of patients bleed quite a bit and they think that they're gonna bleed out in your chair, but they're not. Just give them opportunities to rinse a lot. Keep them as comfortable as possible, because I know sometimes, even for the healthiest of patients, this isn't comfortable. They can taste the blood, they can feel you poking around, and that's exactly what they didn't want you to do. Not only will this make your patient more comfortable, it'll make your job a lot easier too, the easier that you're able to see. The presence of calculus. There could be large subgingival calculus obstructing your pathway to proper probing. If you are getting caught on a lot of calculus, you may have to perform a full mouth debridement to remove some of the larger deposits to get an accurate measurement. Probing is all about accuracy, and we want to be as accurate as possible. If you notice that you're getting stuck on quite a bit of calculus, you may want to refer back to your x-rays, because you can see in your x-rays if there's subgingival calculus. You'll see the little white wings on each of the tooth, and you can use that as a teaching tool also to your patient and show them, look, we got a 3, which is a healthy number on this tooth. However, you can see that the bone level is closer to a 7 or an 8, but we're being obstructed by this large piece of buildup, which is the main reason that you're having the bone loss. Your body will look at this subgingival calculus almost like a splinter. If you were to get a splinter in your finger is going to get red, swollen, irritated, things like that. It's just your body's immune response. When it's in your mouth, your body is responding the same way because it's a foreign object. The bone is resorbing, the gum tissue is swelling, there's bleeding, trying to get that foreign object out of there the best that it can. Probe position. Positioning is a crucial part of probing as well. You want to make sure the probe is running with the long axis of the tooth. You don't want the probe to ever be perpendicular with the tooth. The side of the probe should stay in contact with the tooth at all times. The probe should never exit the sulcus until finished. The more you enter and exit the sulcus while probing, the more irritation it can actually cause. If you cause more irritation, it could cause more inflammation, which means you're not getting an accurate reading. Like I said, accuracy is our biggest problem with probing and the calibration, because not only do our probes need to be calibrated, us as hygienists need to be calibrated as well. We all need to be staying on the same level. This is a picture here of showing us proper adaptation. See how our tooth is angled a little bit? You want to stay along that angle like that tooth, or like that probe. This one's going straight in, so it's actually pulling the gum tissue out where you're getting an improper reading. So you would be going straight down versus going along the long axis of the tooth. Technique. The technique that you use when you're probing is called the walking stroke. You want the probe to walk through the sulcus, sort of like this, but like I said, you don't want the probe to ever exit the sulcus before you are finished with that surface of the tooth, because you could irritate the gum tissue along that side. You can see in the last picture the arrows of the walking stroke, which I have a picture of. They cover the entire circumference of the tooth. It's important to probe around the entire tooth because the junctional epithelium may not be the same everywhere. The steps of the walking stroke. Insert the probe until the tip of the instrument experiences resistance from the base of the sulcus. The base of the sulcus, as we already know, is the junctional epithelium. You want to create the motion of the walking stroke, which, like I said, is bobbing up and down without exiting the periodontal pocket. They say that the pressure that you guys should exert is between 10 and 20 grams. How are you going to know when you're with a patient what 10 and 20 grams feels like? When you're in clinic, they have a couple instruments that you can actually apply pressure to and see how much pressure you're applying to these different instruments. This is an example of the walking stroke. You can see how it just bobs up and down. You're lightly pressing down all throughout all these teeth, and this probe will never exit that sulcus. When you're probing anterior teeth, you want to start on the distal facial of the tooth by inserting the probe at the distal facial line angle. Walk the probe around the tooth with making contact with the junctional epithelium at every point while going down on the walking stroke. Assess beneath the contact area or the coal region and walk towards the facial surface and assess there. The coal region is between each tooth, so it'll actually angle more because, like I said, we want to stay parallel with that long axis of the tooth. So if you were to go straight, it wouldn't be accurate because we see that that little hump right there goes down more because it's following the long axis of the tooth. Continue mesially until you get to the adjacent or mesial facial contact and assess below the contact area. You want to repeat the same thing on the lingual surface or the tongue side. When you're probing a posterior tooth, you want to start on the distal facial of the tooth by inserting the probe at the distal facial line angle. Walk the probe around the tooth with making contact with the junctional epithelium with every stroke. Assess beneath the contact region or the coal region and walk towards the facial surface and assess there. Continue mesially until you get adjacent or mesial facial contact area and also assess below that contact area. The only difference between an anterior and the posterior tooth is the fact that there could be furcation involvement, and obviously the teeth are bigger. They have more anatomy to them, more grooves that you have to be aware of. That's why it's super important to know your dental anatomy, because you could get stuck on something that's not calculus, and it could actually be an enamel pearl, which is a chunk of enamel that's on the root surface of the tooth underneath the gum line. Your 6 probing positions. These are the 6 different areas that you'll measure numbers. So you have 32 teeth in your mouth. I know you have 31.
Right.
You have the most teeth in the room. But there would be 6 numbers for each tooth. The distal facial line angle to the midline of the distal, direct facial. The mesial facial line angle to the midline of the mesial surface. The distal line angle to the midline of the distal surface. Lingual surface. And lastly, the mesial lingual line angle to the midline of the mesial surface. Like I said, you'll have 6 number readings. This is also a good indicator when there's vertical bone loss, because you wouldn't know if there was vertical bone loss if you were only measuring certain areas. However, you could be on one tooth and get a 3. You could go to the very next tooth right next to that reading and get a 7. So that's why it's super important. Like I said, we have to be accurate. We can look in the healthiest of patients' mouths and see nice pink healthy gums, no bleeding. They're brushing and flossing every single day. If you're not, you can look at them and say, okay, I'm only gonna probe a couple areas. What happens when you fall into an area of a 10 millimeter pocket? It's gonna set off an alarm in your head that you have to turn around. You have to take your time again when you should have done it from the beginning to properly probe your patient. What number do you record? When recording the probing depth, you want to record the highest number. For example, in this picture, the clinician is performing the walking stroke on the facial surface of a molar. I know it's really small for you guys, but it's A, B, and C. A and B are 2 millimeters deep. However, C is at a 5 millimeter deep. You would record 5. Like I said, this could be an indicator of vertical bone loss or dehiscence. Obviously, there's something going on there, and you got to figure out what it is. It could be food getting impacted there. It could be active infection in just that area. there could be tartar built up underneath there. This is what I was talking about on the direct facial. A fenestration is just the window. You wouldn't detect that with your probe. That would be detected with possibly a gingival gum flap provided by a periodontal surgeon. A fenestration, these aren't very common, but they are seen, so it's important to know what they are. When you're a right-handed operator, which we only have one left-handed in our class, the seating positions are the same, but on opposite sides of the clock. For instance, when sitting at 9 o'clock for a right-handed clinician, it would be 3 o'clock for a left-handed clinician. When doing the facial of the upper left and lingual upper right, you would sit at 9 o'clock. When cleaning the anteriors of the maxillofacial and lingual, you can sit at 10 or 12 o'clock. So you would be sitting directly at the head of the patient. However, on the mandibular anteriors, the lingual, you can still stay at 12 o'clock to be able to access vision to those teeth, but you want to switch to 8 o'clock for the front or facial surface of them, just because it's easier. Patients will think you're moving all over the place when probing and cleaning their teeth. Now with a left-handed patient, you'll look at the times are polar opposite, like I said, from the right-handed. Maxillary upper right buccal and maxillary upper left lingual would sit at 3 o'clock versus 9 o'clock for a right-handed clinician and opposite sides of the mouth. The maxillary anteriors are still at 12, and the mandibular linguals are still at 12 as well, and facials are still at 8. Okay, so there's an example of one of the probes that we have in clinic. 3, 6, 9, and 12 millimeters. Very basic, simple. We'll have a little mini quiz. And I know it's pretty hard to see from back there. Tooth number, or letter A, could you guys see what millimeter markings that's at?
No, it's a little over 1.
Well, you gotta remember, the markings are at 3, 6, 9, and 12.
A little over 3.
Okay.
Right about 3.
Right about at 3. That one's actually at 6.
Yeah, I'd say the middle one's 12.
I don't have my glasses on.
3, 6, 9, 12.
Okay, I was looking at the bottom.
So, it's 3.
Uh-huh.
Middle
Here's
one's at
another
3,
6.
so there must be some calcium buildup or something.
Yeah. This one actually has another condition. There's a bonus. How much recession is going on this tooth?
3.
Exactly. 3 millimeters of recession. So you actually are having some bone loss there because the gum tissue normally would be up here. However, you had 3 millimeters of recession, then 3 more millimeters of bone loss. So there's actually 6 millimeters there. You can see the level of bone is actually involving the furcation, so you could use your neighbor's probe there. How about on tooth C?
6.
9.
9.
There you go, 9. Now, can anybody guess what's going on this tooth?
It's messed up.
There's some swelling, so there
Infection.
might be some gingivitis. or
Very good.
disease.
There is some swelling and inflammation, saying that there's gingivitis, possibly a periodontal disease. Any patient with a 9 millimeter pocket, there's definite bone loss and definite disease going on. Now we want to go on to measuring the clinical attachment level. This is like a big math problem to me. I'm not good at math. So this was, when I was first learning this, I was like, oh boy. But it's actually extremely easy. Pocket depth minus x. X, you just measure the outside of the gingival margin. When you're measuring the clinical attachment level, you want to measure the total width of gingiva from the gingival margin to the mucogingival junction. You'll be able to see that on the outside of their gum tissue. It's a little bit lighter pink versus red, loose, unattached gingiva. Then you'll measure the periodontal pocket. You're going to subtract the probing depth from the width of the gingiva. Then you have the clinical attachment level. We're now going to watch a video on how to measure that. It's just a minute long.
Attachment level is now calculated for you. Next, we will measure the clinical attachment level when the gingival margin is apical to the cemento-enamel junction. In this case, the patient will have recession present. Again, we will begin by recording the probing depth. When recording the probing depth, the clinician is measuring from the base of the pocket or sulcus to the gingival margin. Here, the probing depth is 111. Again, the clinician is using the tip of the probe to feel for the CEJ and records the recession measuring from the gingival margin to the cemento-enamel junction. The recession reading on this tooth is 2 on the direct facial.
See how there's a little bit of blood there? That little bit of blood your patient will taste. So, like I said, just constantly remember to
clinical
rinse.
attachment level for this tooth with recession, we now add the probing depth to the recession reading. After adding the 2 measurements, the clinical attachment level is 131. If the clinician had only recorded the probing depth, the gingiva in this area would appear to be healthy as recorded readings of 3 millimeters or fewer. The clinical attachment level provides more information about the patient's gingival health status. The clinical attachment level is now greater than the probing depth because of the recession present. Again, Dentrix will calculate the clinical attachment level automatically for you after entering the probing depth and the height of the gingival margin apical to the cemento-enamel junction. The height of the gingival margin is recorded in the row labeled GM. On tooth number 24, the recession is present. The gingival margin is apical to the CEJ, so we enter the 2 millimeter reading for recession in the box labeled GM.
Okay. That was an example on how to measure clinical attachment level on a tooth that has recession, because I know it gets difficult when you just have to add more things to a regular. Okay. So healthy versus diseased periodontal pockets. A healthy periodontal pocket, like I said, ranges from 1 to 3 millimeters. There won't be any blood or pus present. The tissue is pink, tight, stippled, and tight around the tooth, nice and considered healthy. A diseased pocket will be greater than 4 millimeters. There will be blood and or pus present. Pus isn't always just an indicator of periodontal disease. Mostly it can be an indicator of needing a root canal due to an abscess. At that point, when you are seeing pus, push on the gum tissue around your area that you're experiencing pus, and also take a periapical x-ray just to check out and rule out the need for a root canal. The tissue will be red, swollen, loose around the tooth, not tight and hugging the tooth. There will be bone loss present from destruction of the periodontal ligament and the bone around the tooth. These are some of the different stages of gum disease. Like I said, 1 to 3 millimeters here is really nice and healthy. Here's where we're getting into the gingivitis stages. It's around 4 millimeters. You can see some of the buildup starting underneath the gum line and seeing that the tooth or the gum tissue is actually getting a little more red. When you're getting 5 to 9 millimeters, you're seeing here on the root surface, there's quite a bit of buildup, a lot of redness, and you're starting to see a lot of destruction of bone. This is that vertical bone loss I was talking about. You can get a 3 here, 3, 3, and then all of a sudden a 5. This could even be a 3 due to that tooth being tilted, and then all of a sudden you've got a 6. That just goes to show you that your bone level isn't going straight across like it should be. There was something going on down here, possible food impaction, showing that there was problems underneath the gum tissue. Horizontal bone loss is one of the most common patterns of bone loss that you'll see. It all gradually goes down. and it's reducing in height, straight line. The bone margin is perpendicular to the tooth surface. Vertical bone loss is something that we just saw in that picture. It's vertical versus horizontal. I'm going to pass out a case study to you guys, and we're going to end our lecture today by you guys going over this case study.
Thank you, Mrs. Kath, for your